prevalence of IBS. We're talking, this is a big disease. I mentioned that in the intro. What are we talking about? How many people have IBS? Ali?
So the prevalence of IBS is significant. Globally, it's about 11%. That amasses to about 1 billion people in the world, and about 30 to 40 million people in the United States. So, so it's a very common disease and affecting a lot of people. So it's important to address how we treat these patients and how we help them so they can go on with their lives, with their professional lives and social lives, because it's affecting that significantly.
So I'm going to get on my high horse because IBD gets a ton of funding, and it's a 1 million person disease. IBS gets hardly any funding, and it's a 1 billion person disease, or at least 45 million in the US, and probably economic burden is much greater. What's the disparity here? Is it us that's doing something wrong? Is it that the disease isn't respected? Because that affects patients and that affects the clinicians. If the disease isn't respected, the clinicians don't respect it, the patients don't get respected, and it's a funnel down effect.
I mean, this is a complex and important question. We probably all have our own perspectives on it. You know, I think historically we haven't had a really good handle on the pathophysiology of IBS. And it's been confusing. You know, is this a disorder of the mind? Is this a disorder of the body? Is this a brain-gut disorder? And you know, as a result, there's lots of different perspectives and views, which you'd think would be perfect for research. But I think without having clear-cut pathophysiologic models, which is changing, as we'll talk about today, it's been harder to justify research grants, whereas in IBD, some of the basic science has advanced so quickly, and there's so many treatments available. Not that there aren't in IBS, by the way, which is a misconception, but the biological model of IBD has advanced to the point where it feels maybe more justifiable to put money into it. But you could argue the exact opposite, that, well, we've sort of solved a lot of that, haven't cured IBD by any stretch, but IBS is farther behind in funding, as you point out, and there's definitely a disproportionate focus on this condition.
I think the other thing that is very important is that the perception by physicians and I would say patients is that IBD is a morbid disease that actually kills people. You know, so it's associated with cancer, strictures, a whole host of complications that are scary and impactful. And you know, whereas IBS is really viewed as more of a lifestyle disease, you know, which is really unfair given how much these patients suffer. But I think that people tend to not necessarily equate the suffering with importance, as opposed to if IBS, for example, was associated with a greater risk of cancer or some other fatal outcome. I think it'd probably be viewed differently than it is.
I mean, few people understand that the risk of suicidality, for example, which we wrote a paper on, is not trivial among people with chronic abdominal pain. So these are some of the often, you know, sort of whispered secrets about functional abdominal pain and IBS, is that it can really profoundly affect people's quality of life.
Yeah, I mean, I agree with all that. And the complicated part of all of this is that in the mix of this pseudo-chaos is the patient who's suffering and being told, it's not going to kill you. And then they're somewhat dismissed by some clinicians. And so if we come to one point on this topic, don't do that to your patients. I think take them seriously because they have real disease. But that leads me to the sort of risk factors. So what are the risk factors that you think are important in IBS? And we're going to discuss this in more detail later, Tony, but maybe sort of get us a little up to speed on some of the things that are happening.
Sure. So there are a number of different risk factors. We know that IBS, particularly IBS with constipation, is more common in women. It's more equal for IBS with diarrhea between men and women. We also know that people that have had an infection, and I think we'll talk more about that and the pathophysiology, tend to have a higher risk of developing IBS. And we know that people that have underlying psychosocial factors, including like anxiety, will have a higher risk of developing IBS. There's also been some data on socioeconomic status. The lower the status, maybe the higher the risk of developing having IBS-related symptoms.
So speaking of post-infectious, Dr. Razai, and again, we're going to get deeper into this, but just as a flyover, what's going on there? What do we know, or what are we starting to know in terms of post-infectious IBS?
So that's a fascinating concept in IBS. So whenever we pick up food poisoning or infectious gastroenteritis, especially with gram-negative bacilli, which are the usual bacteria that you hear on the nose, Salmonella, Yersinia, Campylobacter, or E. coli, you develop that infectious gastroenteritis, but as that bacteria leaves your body, you have roughly 12% chance of developing IBS symptoms. Which is called post-infectious irritable bowel syndrome for post-infectious.
So it's literally a cause of IBS.
Yeah.
So it's one thing I've been saying lately, and this is a little off the cuff, but today we actually know more about the ultimate cause of at least a segment of IBS than we do of IBD. Nobody knows what started the IBD. There's no like event, but in IBS we have an event, at least accounting for a portion of IBS. What portion of IBS, let's say 100 people show up in your office with DIBS, what portion of those do you think, it's going to be a varied opinion on this panel, but we'll start with Bill, what portion do you think are post-infectious in your experience?
Of the D group?
Of the D group.
Yeah, probably somewhere between 10 and 20% is what I would guess. You know, and I think there is a lot of debate as to what the right number is, because we don't have great prospective data to really guide us that way.
And it's hard to know because some people may recall a particular episode when they had traveler's diarrhea or they got really sick, and then others may not really remember that, but they may have been exposed you know, to the pathogen and maybe had some grumbling stomach and just don't really remember that instance, but yet they were still exposed. And that could potentially still
I think that's
be
what
a trigger.
complicates it. I'm going back to Bill because I give you all the tough questions. What are the unmet needs? And that's very vague, but I think there's a lot you could say here because there's so many unmet needs, but just give me your high-level opinion. What are we missing? What do we need to do?
Yeah, so I think this is really the question, right? And the easy answer would be to say just more effective therapies, and we do always need more effective therapies, but really what we need, in my opinion, to make the quantum leap in terms of solving this problem is greater specificity in regards to the diagnosis. In other words, helping not only identifying patients on the basis of symptoms, but using symptoms and then having biomarkers to help us to parse patients on the basis of pathophysiology, because that's the way that we'll be able to choose the right treatment for the right patient and go from 40% of the patients getting better to 80% of the patients getting better, right? That's what we really want. So to me, that is the real unmet need.